mixture of classic cases, cases with interesting findings. And as Nat said, please feel free to interrupt me. Please feel free to ask questions. If you guys want to chime in with certain findings and things, that's great. If you don't want to, that's okay as well. But happy to welcome all questions and things. So each of these is going to start with a little bit of history. One of my favorite parts of chest imaging is that you really need the history to guide you because the lungs only react in a certain number of ways. They're an organ that doesn't have many tricks, so you have to really know what's going on with the patient to know what the diagnosis is going to be. So this patient that I'm going to show, they have a history of myelofibrosis, and they got a stem cell transplant for that, and they needed pretty regular platelet transfusions because of low platelet counts. And so they recently got one, and now they have acute onset shortness of breath. So I love starting with the chest x-rays when I have them. So I'll just kind of show and tell this one. But if anybody wants to unmute and tell me what they see, I think that's awesome. So what I see when I'm looking at this, it's a frontal and a lateral. A lot of busyness going on in the lungs, right? So there's sort of hazy, consolidative-ish opacities that are mostly central, and there's a lot of lines in here too. And what I like to tell my residents is when I see way too many lines, there's something going on with the interstitium, right? So you don't have good air spaces between these lines because there's lines everywhere. And I think on the lateral, there's probably a little bit of pleural effusions too, although it's a little hard to see. So I'll go to the CT now. Anybody want to take a swing at what we see? And if not, that's okay too. I'll give everybody a second to sort of digest the images. So when I look at this, a couple of things really stand out to me. So I mentioned all those lines that we were seeing on the chest x-ray, and I think we're seeing something very similar here on the CT. So when you look at the periphery, right, we have an axial and a coronal CT. There's a lot of these prominent lines out here, right? And it's more obvious on the coronal, I think. All of these lines out in the periphery. And that's interlobular septal thickening, right? That's what's going to cause those lines on the chest radiograph. So the interlobular septal are thickened. Here are all those opacities that I said are pretty central. It's really interesting if you look here at the bases, this area is relatively spared from those ground glass opacities, but this central region, there's a lot of them, right? And they're even consolidative in some of these areas too. So we've got interlobular septal thickening, we've got some consolidations in ground glass that is mostly central, and we've actually got bilateral pleural effusions as well. Anybody have a diagnosis to sort of join these things together? And I apologize, I can't see the chat on my screen if anyone's chatting in there. So this is actually a great look for pulmonary edema, right? So it's very interesting. This patient, it's very classic findings of pulmonary edema, but the situation is pretty peculiar, right? So they are getting these transfusions pretty regularly. So people who get transfusions, a couple of different things could happen, right? If you get a lot of them, you could potentially get volume overloaded, right? Because it's not like they just put platelets in with those transfusions, there's volume that goes in with that as well. And this person, I think, needed them pretty regularly, at least once a week, if not a couple of times a week. The other thing that can happen is you can actually get an immune response from a transfusion, which can cause non-cardiogenic pulmonary edema. So hard to know what exactly happened here with this patient. One of the two must have happened, but it's pretty interesting and something that you can see, sort of a transfusion syndrome in people. All right. And again, if anybody has questions, feel free to interrupt me. I'm just going to keep showing cases and we'll keep talking about stuff. So next case, this is a 59-year-old and they're coming in with signs of sepsis. On the left is the frontal stress radiograph from when they presented now, and I gave you one from 3 months prior on the right side. Give everybody a second to kind of take a look and digest what we see. All right, any takers for any of the findings? So my eyes are drawn up here at this left lung apex, right? A lot of busyness going on up there. And 3 months prior, sure, they probably had some biapical scarring, this little bit of thickening up here, but this area was relatively clear. So something that's, relatively subacute-ish, maybe acute in some ways. Very consolidative, right? You can't really see through that. And you have this interesting area right here that isn't consolidative, but sort of is in that region. So if we try to delineate our structures, right? So here's trachea. This is our aortic arch coming down to our descending thoracic aorta. And these are the rest of our mediastinal contours. So it's somewhere in that sort of left suprahilar region. Now let's go to the CT. So you can sort of see why it looked that way, right? This whole left upper lobe, or at least most of it, is very consolidated, right? And there's probably some volume loss, a little bit of shifting here of the mediastinum to the left. Now, when we see things like that, I worry a lot about cancer, right? So to me, it's cancer until proven otherwise. Something is obstructing that airway and causing that to collapse so quickly. Now, granted, maybe the cancer was slowly growing and it finally obstructed the bronchus, but that's what I'm always most worried about. Now, other things can happen, right? You can get mucus plugging in the airways that cause things to sort of collapse a lobe, and you can get infection because of that. But cancer is always in the forefront of my mind. And this person actually got a PET, and you can see on the right side, there's this focal nodule here, which is very FDG avid, and that's causing that left upper lobe collapse. I think I'm getting a little reverb back on the audio from somebody. I don't know if someone needs to just turn the volume down a little bit or not. So this is left upper lobe collapse due to an obstructing cancer. And I think this is really cool. I want to show everybody this here. So this is a coronal CT, these two images on the left, that I played with a little bit. And what I did was I made an average intensity image. So I summated a bunch of the slices in the coronal dimension. Right, I think I picked 60 millimeters or 70 millimeters or something whereabouts that. And I summed those all together. And when you do that, you get this representation that looks kind of like a chest radiograph, right? So I think this helps explain what we see on the chest X-ray. So these two images, the one on the left is a little bit more towards the anterior portion of the chest, right? You could see the aortic arch pretty clearly, and you could see the trachea very clearly. The one in the middle is more towards the posterior aspect of your chest. And I know that because look at how clearly I see the vertebral bodies, and look at how clearly I see the aortic arch and descending thoracic aorta. Now, I pointed out before, let's go back, you had this interesting finding here of this like air, it looks like, around the aortic arch. And here's why you see that on the frontal. So when you get more anterior, the way the left upper lobe collapses is it likes to collapse up into the front, right? This one I would say is more up than towards the front, although it's doing it as well. So that's why this area more anteriorly is going to be very opacified. But when you get more posterior, right, your left lower lobe actually goes pretty high. The superior segment is pretty high in your chest, and that area is going to stay aerated, right? It's actually going to get pulled up a little bit because of the volume loss of your left upper lobe going down. So when you put all these things together, right, the tricky thing about a chest x-ray, it's all these layers just summated into one image. This is what you get. And this is actually what we call the Leftosausschein. And it's a good look for left upper lobe collapse, right? So when I see collapse of the lobe, I worry about cancer. You could think about infection. In inpatients, you could also think about, is there a mucus plug that just happened? And sometimes in kids, you can think about foreign bodies, right? Unfortunately, they have a lot of access to swallowing things that they shouldn't be. So all things to think about. And this is a good companion case that I want to show. Now, this is actually really difficult in my opinion. These frontals are very, very hard in left upper lobe collapse sometimes. If you sort of step back from the image and really just try to look at it very broadly, one might notice that this is relatively darker than this side, right? There's sort of a white haze over that whole left hemithorax. And when you look at the lateral is incredibly helpful here, right? There's this interesting edge here, and then this whole region anteriorly is more opacified, right? And that's because you're getting the same thing. This is a completely different patient, but a very similar finding. You have an obstructing lesion here. This is an FDG PET, so very avid lesion here. That's collapsing that left upper lobe. So sometimes left upper lobe collapse can look very dense. Sometimes it's very, very subtle on the chest radiograph. And again, that's because your left upper lobe likes to collapse up and towards the front, right? And so if it collapses more towards the front like this, the findings on the frontal will be very subtle. All right. Another case here. So this is actually a woman with breast cancer. She was fully treated. She got neoadjuvant chemotherapy, and she got surgical resection. And then she just finished radiation therapy about a month or so ago. And she's coming in, she's just sort of getting regular scans. I think she had a couple of pulmonary nodules that we were just checking on, making sure that they weren't malignant. But her findings are really interesting. So let's everyone take a look at this for a couple of minutes. Two coronal images. The one on the left is the one I'm talking about currently, and the one on the right is a follow-up 2 months later. All right. Anyone want to shout out any findings? So what do I see when I look at this? So there are these opacities here, right? But they look really weird, right? We've all seen consolidations. We've seen ground glass opacities. These are kind of a little bit of both and a little bit of funny looking, right? So let's focus on this one down here, right? So it's sort of peripherally very dense, right? Peripherally, it looks like a consolidation. Centrally, kind of looks like normal lung, right? I'm not really seeing any opacification there. And you sort of have the same thing going on here in the right lower lobe. And there's a few other opacities scattered about that I'll tell you look very, if you scrolled through the whole image, look very similar. And then 2 months later, you have a very similar distribution. Granted, the opacities maybe are a little bit larger, but they look a little less dense in my opinion, because now they're mostly ground glass instead of the consolidation that was there before. So what are you thinking about with this patient, right? So they have a history of cancer, so you always have to sort of have your ears and your eyes up thinking about, could this be a MET or some sort of recurrence? Granted, this would be a MET in this case. But what are the other possibilities here? And so do we think this is an infection? I'd say probably not, right? I didn't say it's explicitly, but she's not having a cough. She doesn't have a fever. There's no sputum production or anything like that. No sick contacts recently. Um, it's bilateral, so it's something affecting the lungs sort of more globally. And with her history of all this chemo and this radiation, and I think she's on some immunotherapy now too, you can get organizing pneumonia, right? This is actually another slice, slightly more anterior in the chest, where you're getting the same thing. And then 2 month follow up, it's resolving a little bit. So this is an organizing pneumonia pattern, right? And I think it's something that people often struggle with. And so let's go back to the findings. This, what I called out before, the peripherally dense, centrally not as dense or normal, that's what's called an atoll sign or a reverse halo sign, meaning that the periphery is more dense and the center is less dense. That's actually a really good finding for organizing pneumonia. You can see it in some other entities, one of which we'll actually see later on in this presentation. But when I see that, I'm really thinking about organizing pneumonia. Now, to take a step back, organizing pneumonia is a very broad disease and it's a very broad pattern of opacities in the lung. It can mean a lot of different things. So you can actually get it with infection. You can get it with many different types of inflammation. The thing I think about the most is some sort of drug reaction, especially with people who are on immunotherapy, that happens a lot. You can actually get it at some of the leading edges of cancer. You can get a little bit of organizing pneumonia, and you can get it as a response to something else going on. It's a very, very broad disease. So when I think of organizing pneumonia, I think, okay, we have a pattern here, but now we need to know why. And that's where the history is going to be very key to help your clinicians figure out, okay, what is going on with this patient? Are there any weird medications? Do they have a recent illness? And I'll show you another example here. This is actually a patient who had a bilateral lung transplant. They had COVID just a few weeks ago, and it's similar but different, right? So if you look over here on the right image, in the left upper lobe, you have kind of an atoll sign going on, right? Peripherally more dense, centrally less dense. But there's a lot of other opacities too. There's mostly ground glass. I would say there's peripheral spots, like here in the right upper lobe. But there's also some that are peribronchovascular, like here in the left upper lobe. So it's not just the fact that I'm seeing the atoll sign. You actually only see that in roughly 20 to 25% or so of cases of organizing pneumonia. But I'm seeing a lot of bilateral opacities and a lot of areas of sparing. If you look here, these opacities look what we call perilobular. Now it's kind of a misnomer, and I'll explain more about that. So think about the secondary pulmonary lobule, right? It's the most kind of anatomic unit of the lung. At the center, you have your bronchus and your pulmonary artery. At your periphery, you have the walls with the veins and the lymphatics, right? And so these opacities, you could sort of imagine that they're going around a lobule, right? Now, realistically, what's happening in these patients with organizing pneumonia? It's not that it's sparing a particular lobule, it just that has that look, we call it like an arcade look as well, that it's going around lobules. So this is what I think of more when I think of organizing pneumonia. If you have an atoll sign or a reverse halo sign, that's great. It's going to really help your diagnostic confidence. But if you don't let that exclude a diagnosis of organizing pneumonia for you. This is a great look for organizing pneumonia as well. And in this case, we see this from time to time, these people who get COVID, and then it kicks off this inflammatory response in the lungs of organizing pneumonia. And some people will actually need a steroid burst to make this go away. Some people resolve on its own. I don't know how well described it is in the literature, but I'll tell you, I've seen this several times now. Okay, new case, right? So this is a patient who's in the hospital, so very sick, right? They're in advanced heart failure, and they're actually admitted with cardiogenic shock. Team is trying to figure out what to do. They're thinking about doing an LVAD. And for those who don't know what an LVAD is, it's a left ventricular assist device. Really, it's when your heart is not doing its job and it needs some help pumping the blood out to the rest of your body. They're going to put this mechanical device in that will help reroute that blood to your aorta because your left ventricle presumably isn't able to do so. Now, these are very zoomed in, so let me give you a little context here. So the left is an axial image. The right is a coronal image. Both of them are very, very zoomed in. Focus your eyes right here where I'm circling on this axial and right here on these coronals. Give everybody a second to take a look at them. I'll tell you, the rest of the lungs looked relatively clear. I think they had a little bit of interstitial edema, which given the heart failure is not surprising. But to me, this opacity looks weird, right? And I'd describe it somewhat similar to the atoll sign or the reverse halo sign in some ways, right? It's peripherally dense, it's centrally more ground glass, and it's very focal, right? I'll tell you, these opacities didn't exist anywhere else in the lungs. So very odd, not something that the team expected, right? Because they were just kind of looking at anatomy, thinking about doing this LVAD. They wanted to look at the aorta, and this is what we found. Anybody have any ideas of what this might be, or maybe what a differential could be for this? So let's talk about some possibilities, right? Do we think this is an infection? I would say probably not. Very focal, and the patient doesn't have any infectious symptoms, right? No fever, no cough, sputum, anything like that. So possible, but I would say less likely. Um, is this a good look for pulmonary edema? I would say no, right? Again, this is the only real opacity besides a little bit of interstitial edema that the patient had everywhere. Is this trauma related? No, the patient doesn't have any recent falls. It didn't come in with trauma. Could this be aspiration? I would again say no because it's mostly in the right middle lobe, very anterior. So while it could be, it's sort of an uncommon location for that. So let me show you this. We had them get a PE study, and that obviously is very leading to what the diagnosis might be. But I did some two clips here of the pulmonary arteries. So focus your eyes right here on the left, and then that's, oops, same artery here. You can see there's a PE going right to that spot, right? Here are those opacities, and here's that pulmonary embolism. So this is a good look for a pulmonary infarct. And it's something that I know I sometimes forget about, and I think trainees kind of regularly forget about on a non-con. We're worried about all these other things, but just because we can't see the vessels doesn't mean there isn't something wrong with the vessels. So when you see very focal opacities that are peripherally more dense, centrally less dense, think about PE. Could that be a possibility, right? This patient, presumably with how bad their heart failure wasn't very mobile. I'm sure they were mostly in the bed all day, maybe being sat up from time to time, maybe working with physical therapy from time to time. But because of all that bed rest, I wonder if they were more prone to getting a PE because of that. And here's a companion case to that. So this is, I'd say, a middle-aged patient. They had some new sharp left rib pain for the last few days, worse when they took in some big breaths, and no other leading history, no trauma, no recent illness, no cough. And here's the chest radiograph, a PA frontal and lateral. Give everybody a second to kind of take a look and think about what we see. All right. So let's start with the frontal. I got to tell you, I don't see much on the frontal. I think it's looks relatively clear. The lateral here is what's really helpful, and will draw your eyes back to the frontal, I think. So on the lateral, right, what do you want to look for on your lateral chest radiograph? Well, one of my big things is all the clear spaces, right? So what are your clear spaces? You have retrocardiac here, you have retrosternal, retrotracheal, and then we always look for the spine sign, right? The spine should get less dense going down. That all looks pretty good to me. Another not really clear space, but space that should be relatively clear is this area overlying the heart, right? I think some people's eyes sort of don't get drawn to that location because it's always a little busy, but it seems like there's something very focal right here, right? If we go back to the frontal, pretty hard to locate it. One wonders if there's maybe a little bit going on here or here, but I think the lateral is what really sold me on this one. And when you take a step back, look at the costrophrenic angles, right? This one looks very crisp, but this one doesn't go down. It doesn't do the usual dive. So there's a little effusion here as well. So focal opacity and a small effusion. And this was actually a case that I read. I called the clinician up because I was like, oh, hey, this is, maybe if they have a cough or something, I think this could be pneumonia. Like, what's going on with this patient? And they actually said they weren't worried about pneumonia at all. He said the sharp rib pain was pretty acute onset last couple days. And again, no trauma, no sick contacts, no anything like that. So we both sort of wondered for a little bit, and I was like, well, do you think this person could have a PE? And they said, yeah, I'm not sure, it might be. And this is just what we saw on that frontal chest radiograph in the lateral, right? Here's this little opacity here. But sure enough, this vessel on the PE study was taken out. So they did have a PE, and that's what that opacity was. So I think this case demonstrates a couple of really helpful things, right? Number one, just talking to your clinicians, right? Asking them what they think, what are they worried about, what does the patient look like? I think the art of talking to clinicians is super, super important, again, especially so in chest radiography, because an opacity can mean a lot of different things, right? If you told me this person was coughing up green sputum, had a fever, had a recent sibling who was sick and they were spending time with, I'd be like, okay, it's probably pneumonia. But this case, talking with them really led everybody to get the appropriate studies done, right? The PE study, and to make a diagnosis relatively quickly in this patient. So the moral of these two companion cases is when you have non-cons, when you have chest radiographs, keep PE in your mind. Like, could this be a PE?
Dr. Dr. Harowitz, I would like to interrupt a little bit. When you
Yeah.
show us cases and you point out to the places it has abnormalities, we don't see your arrow on the screen. You may
Oh
have to,
no.
yeah. So it doesn't come with the arrow. So we just see the images, but we don't see the arrow. I
Interesting.
think
Okay.
that's the way probably the WebEx is built, but
Okay.
probably yeah. If it's on the PowerPoint like this, we see it. But if you
Okay.
put it on the slide presentation, we cannot see it.
Okay. So you can still see it right now?
Wait, hold on. Can you do it again? Can
Yeah,
you
I'm moving.
now I see it. Okay,
Okay.
thank you. So I was
Okay.
wrong. I was looking at what you're saying and then I cannot see your arrow. Now
Okay.
I see it. So, sorry.
Okay. No, don't be sorry. I'm glad you told me. So let's
Okay.
back up. I'll show this case again. So this is what I'm pointing out here, and this now we know it's the lingula, right? Here's this pulmonary artery here, right? You could see some of these are veins, but some of these are definitely pulmonary arteries, right? So these are very bright. This one's not so bright. That's your PE, right? So this opacity here correlates with this one here. All right. Well, I'm glad I know that now. We'll stay on this so everyone can see my arrow. And if the arrow goes away, please somebody yell at me and say, hey, I can't see what we're talking about. So another case, this is a 35-year-old. They have a history of using IV drugs, and they're presenting with sepsis. They were actually a transfer, I believe, from an outside hospital. So we're still gathering info on them. Very busy CT, two axial images from the same CT. Let's everybody sort of take a look and digest what we're seeing. All right. Messy CT. Any takers for any of the findings? So a lot going on in this case, right? So let's start with here on this left image. So I'm seeing multiple peripheral opacities. Almost all of them appear cavitary, right? Look at this air within this opacity here. This is a very rounded one that has a lot of air. Another nodular one here with some air. And when we go down, we're seeing sort of the same thing, these big sort of nodular consolidative opacities. Think about distribution, right? Whenever we see opacities, we need to think about what is the distribution. I would say these are mostly peripheral, right? Some have a slight peribronchovascular extent, but they're all pretty peripheral. So in somebody who we know uses IV drugs and shows up peripheral cavitary consolidations, those things should sort of ring some bells in your mind about potential diagnoses. Anybody want to shout out?
Septic pulmonary emboly.
Yeah, excellent, awesome. So nail the diagnosis. Now, this is where you get kind of the next level of being a radiologist, right? So you see that, where do you want to look next? On this same CT, right? What piece of anatomy should you check out next? Let's go right here. Oh, go to the next image. There we go. So it's the heart, right? So this is how you get your next like higher order thinking of these people, right? When you see septic embolus, you need to think of, can I find a source? So you should be looking at the heart and looking at the valves specifically. Now, on a regular chest CT, you're rarely going to get a very clean, crisp look at the valves, right? But that's not what I'm saying that you should be looking for. What you should be looking for is big blobs that look like this. So this is a hypodense sort of ovoid opacity here. It's in the region of the tricuspid valve, right? I don't know exactly where the tricuspid valve is, but if I had a guess, it's somewhere around here. And so that worries me that that's a vegetation, right? So this is how you can help your clinicians, right? We know there's septic emboli, we nailed that diagnosis. Now, can we point out where the problem is at? And it's right there. And so all of these are just shooting off through the pulmonary arteries. That infected material is going out and getting lodged into those distal vessels, those distal pulmonary arteries, and you're getting those cavitary consolidations because of that. So very good. This case is septic emboli and tricuspid valve vegetation. So you see the septic emboli, go look at the heart. Again, it could be very blurry. And if you have a non-con, you're going to be pretty limited. But if it's contrasted exam, just take a look. Look at your valves, all 4 of them, right? Tricuspid, mitral, aortic, and pulmonic, and see if you see anything suspicious. Okay, another patient. So this one has a history of cardiac sarcoidosis. They were treated with a heart transplant, and they were doing pretty well until they came into the ED. They're having fevers, they're having chills, and they're having myalgias. And this case is super interesting to me. So let's everybody take a look. We have an axial on the left and a coronal on the right, CTs, same CT. Anybody want to shout out any findings? So I think everyone's eyes are going to be drawn here to the right lower lobe. Now, I would say this looks pretty similar to some of the other opacities I've shown you guys, right? It's sort of peripherally dense, centrally more lucent, right? In this case, it's filled with some ground glass, ovoid, wedge-shaped. Now, what I'll tell you is, do we think this person has organizing pneumonia? I would say probably not, right? It's one opacity, that's possible, but organizing pneumonia likes to be bilateral, multiple spots. Could this be a pulmonary infarct, right? We saw a couple of those today. And I would say maybe, but the pulmonary infarcts from PE that we usually see are not quite this big. This would be a pretty massive infarct in somebody. Not saying it's not possible, but usually they're a little bit smaller than this. And the most interesting thing for this patient is that their history, right? So I mentioned they had the heart transplant. Anybody who has a transplant is going to be immunosuppressed. So you need to be thinking about all those weird infections that they can get. And really any infection at all. Those people are very, very prone to infections. Does anybody have any idea of infections that can give you this sort of look? And this is a tough one. So when I see this look in someone who's immunosuppressed, it looks sort of like an infarct, but it's very big. I worry about fungus that is angioinvasive. So the ones that I'm specifically worried about are what this turned out to be. Just trying to go to the next slide. There we go. And that should say mucor, not muco. Mucormycosis. And you can think of angioinvasive aspergillosis, right? So why do we get these opacities in this? So these fungi are very invasive into the vessels. When they invade those vessels, you're doing the same thing as a PE would, right? You're cutting off that blood supply, which is why you get this look that looks like a pulmonary infarct, right? That other case that I showed y'all looks very similar to this. This is just a lot bigger. So you get invasion of those vessels, you infarct that piece of lung, and that's because of either mucor or angioinvasive aspergillosis. So when the infectious disease team or internal medicine team comes down and they have a patient like this who's immunosuppressed and you see this, tell them you are most worried about those 2 things. Now, the tricky thing with mucor is it's often pretty difficult to diagnose because all of this tissue is just infarcted. It's hard to get a sample that is actually positive for mucor. So sometimes you, as the radiologist, have to be the one that be like, no, I'm very worried about either muco or invasive aspergillosis, angioinvasive aspergillosis. And sometimes I've had colleagues who have been in other institutions where they'll actually do a fine needle aspiration percutaneously of this to try to get tissue to help guide the treatment. But even if there's a lack of tissue, or a lack of microbiology rather, I would be very, very worried about this diagnosis in this patient. So opacities that look like infarcts but are really big and immunosuppressed, keep these in the back of your mind. All right. New patient, acute onset shortness of breath, and they have a history of an MI a few weeks prior. So I'll tell you, we're going to shift a little bit. I showed a lot of thoracic cases, but now I'm going to do a couple of cardiac cases. All right, and it's okay, I'll walk everybody through. People will generally have different degrees of comfort and experience with cardiac imaging, and that's totally fine. But what I already pointed out on some of our chest CTs, that even if they're just doing a regular chest CT, you can see heart findings. So make sure you're always looking for those. All right, so I'm going to start out with the lung windows. So let's everybody take a look at the lungs, and then we'll get to the heart next. All right, so what am I seeing? And if anybody has a diagnosis so far, feel free to interrupt me, shout it out. It'll always be welcome. I'm seeing some interlobular septa that are a little thick, right? Not a ton of them, but here and there, there's some thickening. We get lower down that these are very central opacities, right? Sort of sparing the periphery. So it looks similar to our case that we had earlier of some pulmonary edema. So let's presume this is pulmonary edema. Now you'll notice there's contrast in the heart and in the vessels, so you should always look at them if things are contrasted. And I'm zoomed up here. So these are two axial images. I'm just magged up on the heart. It's a little motiony. You could tell if you look over at the right atrium and the right ventricle here, there's some motion, but you could still see things pretty crisply, right? So everybody take a look, and to point out right atrium, right ventricle, left ventricle. And on the right image, this is all your right ventricle, right? Very thin walled, a lot of trabeculations. And this is a part of your left ventricle here. And I think cardiac things can be really tough on just the axial images alone. So what I'll tell people is that, if you're worried about something with the heart, I would be ready to reformat into one of the cardiac planes. Or an easier trick even is if you have a sagittal reformat, you can take a look at that. Right, so here on the left is that last image that I just showed you, axial cut, just kind of low down in the heart. And this is just a regular sagittal. I didn't do anything fancy in terms of multiplanar reformats. Anybody see anything wrong? And on the sagittal, let's point out, right? So this is a kind of a donut. So that's your left ventricle. This is very thin walled with a lot of trabeculation. So this is your right ventricle. This is actually your right ventricular outflow tract and probably your proximal main pulmonary artery here. Anybody see anything weird with these images? So as I said, when I was talking about the left ventricle, when we get sort of this sagittal or short axis view, I think of the left ventricle as a donut, right? Thick walled, but the wall should go all the way around exactly like a donut is. Well, to me, there's a loss of that donut down here. It looks like somebody took a big bite out of it, right? So there's a big area here that looks like it's now communicating with the right ventricle, right? This should go all the way around and it doesn't. So what's going on here in this patient who has acute onset shortness of breath? They had a myocardial infarction a few weeks ago, maybe 4 or 5 weeks ago, and now they're showing up with this. Well, this is actually a post-infarct ventricular septal defect. So you can get this sometimes, right? So if you have a myocardial infarction, right, you cut off the blood supply to that tissue. That tissue now is weakened. It's probably going to undergo some remodeling. It's probably going to undergo necrosis and some like fibrous tissue that's going to be deposited if you don't presumably, restore the blood flow to it. And what can happen is because that area is remodeled and weak and different than the rest of the myocardium, it can actually just burst. And in this case, it burst into the right ventricle. When it does that, think about what's happening to your blood flow, right? Now, all of that blood, maybe not all of it, but a good portion of it in your left ventricle is being shunted into your right ventricle. So there's a left to right shunt. Now, your pulmonary arteries are seeing so much more blood flow than they're used to, right? Because they're not just seeing blood from the right ventricle, they're getting all that extra coming from the left ventricle too. So you're overloading your pulmonary arteries with all this blood. Presumably, the pressures are going to go higher because if you have more blood, more pressure. And that is going to cause fluid to leak out from those pulmonary arteries into your pulmonary interstitium and into your pulmonary alveoli, which is what gives you the pulmonary edema, right? And this happened presumably pretty abrupt. It just burst, and then that's why this person had acute onset shortness of breath. So the heart can be tricky. I like to go chamber by chamber, just make sure everything looks good. I say, make sure you look for holes that shouldn't be there. And big globs that shouldn't be there, kind of like that tricuspid valve vegetation that we saw earlier. And these post-infarct VSDs can sometimes be very obvious and sometimes very subtle. I'd say on the axial, this one was very subtle and difficult to see. Here's one that I'd say is not so subtle, right? So this is axial images, 2 of them, right, to point out the normal anatomy. This is your right atrium, your right ventricle, your left atrium, and your left ventricle. And then what is this huge glob here, right? Very big ovoid opacity. It looks like it's being filled with contrast. When you scroll down further, you can see this lateral wall has just completely blown out. So this is another patient who had a myocardial infarction maybe 4 or 6 weeks ago. They came in, I think they had some acute onset shortness of breath and chest pain. And this huge rupture, which I guess it's somewhat of a contained rupture because if this just was ruptured and kept going, your whole pericardium would just be filled with blood and presumably you'd tamponade and pass. But this contained itself in some way, but it has a lot of mass effect on the heart. So this is a pretty in-your-face myocardial infarction that burst. This one I'd say is really, really difficult. So one of the things when you're thinking about the heart on either dedicated or non-dedicated cardiac imaging, on your axials, when you're scrolling up and down, I want you to scroll so far inferior that you can't even see the heart anymore. That's when you know you've cleared the heart, right? And what do I mean by that? So in this case, this is 2 axial images, relatively low down in your heart. You can see this is the descending thoracic aorta here. This is actually your IVC, right? So we're below the level of the right atrium because your IVC is hooking into your right atrium. And what I'll point out is that the most obvious thing here is that there's a ton of fluid in the pericardium, right? This is a large pericardial effusion. So when you see a big pericardial effusion, you need to think to yourself, what's wrong? Because something is very wrong. Does this person have a history of malignancy and maybe they have pericardial mets? Did they have some sort of trauma, right? Maybe some rib fractures that were near the pericardium. Or is there something else maybe pouring blood into that region? Infections can also do it too. But what I'll point out is that when we keep scrolling lower, right, so this is your right ventricle and your left ventricle. This right here is probably the very tip, the very apex of your left ventricle. But what's this really weird ovoid area here that has contrast in it? Right? So to go back to what I said earlier, when the heart looks weird, look at it in different planes. Things will look a lot more obvious in different planes. Right? So here, it's just a coronal on the left and a sagittal on the right. I didn't even do dedicated cardiac planes. And just to take a step back from that, dedicated cardiac planes, you can reformat all these different views of the heart. Cardiologists do it pretty often with echo. We'll talk about a 4-chamber view, 3-chamber view, 2-chamber view. If you're not familiar with that, that's okay. Just know that there are different ways that you can make the heart look with multiplanar reformats to get different views of the heart. And if you don't know how to do that, I would just look at the coronal and the sagittal because it's a pretty good start. The coronal here is the most helpful to me. So let's back up, like, what anatomy are we seeing? So these are your pulmonary arteries. If we come down, this is sort of that thick donut that I was talking about. So this is your left ventricle. This is probably part of your right atrium here, right? You can see the contrast density in your hepatic veins and your IVC is very similar to that. And what is this guy? So there's an outpouching here. It's going inferiorly, so it sort of lines up to that inferior thing that I was pointing out here. And this is a sagittal view. You could also see you sort of lose this donut inferiorly here. This is little outpouching here. So this is another post-infarct VSD. Now, all these were in different vascular territories, right? You have your three main coronary arteries. They each supply sort of specific regions of the heart. So different MIs, but the same result. These post-infarct ruptures. Sometimes you could rupture into the pericardium, such as in this case with a huge pericardial effusion. Sometimes you rupture and contain yourself, right? There was that one that was very big that was just sort of next to the heart. And sometimes you can rupture into other chambers in your heart, like a post-infarct ventricular septal defect. But if you don't scroll all the way through your heart, and if you don't evaluate each chamber, it's very easy to miss some of these findings. Anybody have any questions about those sets of cases, these post-infarct VSDs and ruptures? All right, a few more cases left, more cardiac to come. So this is a patient, I would say, I think they're about 40 or so, with recurrent chest pain. So these are two axial images. This was a dedicated cardiac CT. So you'll notice that you see these structures very crisply, right? That's because there's gating involved. We gate to a patient's EKG. And when you gate, you can pick parts of the cardiac cycle that really the heart doesn't move a lot in. And when you do that, you can see some of these things very crisply. By decreasing your field of view and really honing in on the heart, you also get better spatial resolution here, right? To step back for CT for a second, CT, what you see on the screen is just a bunch of what we call voxels, right? Imagine a grid overlying your screen. Those voxels stay the same size. So if I focus on a patient's whole body, right, there's multiple structures getting into each voxel. But if I pick my field of view and I make it very small, you can imagine there's smaller pieces of anatomy that are fitting into that voxel now. And so you can delineate structures in that area very easily, or more easily compared to a big field of view. So where am I on this? So this structure here is the aortic, ascending aorta, right? Here's some of your sinuses of Valsalva. This structure here is your main pulmonary artery, right? That's your ventricular outflow tract. This back here is your left atrium with your pulmonary veins dumping in, and your left atrial appendage. So this is the region where the coronaries come off. So let's all take a look, let's see what we see. All right, so what catches my eye first is that this is your left main, getting into your circumflex and your LAD. It's very big, right? So to show sort of a comparison, you scroll lower down and this is the same patient, same exam. This vessel right here, between your right atrium and your right ventricle, is your right coronary artery. And this is your distal LAD. These are normal sized vessels. This is what I expect, couple millimeters big. These vessels that I'm seeing here are ginormous in comparison. So when you see big coronary arteries, I'm already thinking something's wrong, right? Especially when they're diffusely big. And so the first thing that I think of when I see that is there a fistula somewhere? So let's trace out this person's coronaries. Now, these are an axial and a coronal image but they're a maximal intensity projection image. And what that means is we're summating a bunch of the slices again, similar to the stuff I showed you before with the chest x-rays, but a little bit different. So when you summate a bunch of those slices, you can more clearly see, especially on this coronal, look at this loop-de-loop here, right? Like it looks like a piece of string that's looping on itself. So this is part of your left main. It's looping all the way, and it's actually connecting with this structure here, right? Anybody know what this structure is? So coronal image, big vein dumping into your right atrium.
IVC.
Very close. So IVC is going to be lower down, right? So this is your SVC because it's higher up, but very close. Your vena cava, right? And that is not where your coronary should be going, right? Your coronary overlies your heart normally and supplies that myocardium. So you can actually see it's dumping into that, and it's dumping into the right atrium. So it's creating a big fistula, right? So this is actually called a coronary cameral fistula. Now that name to me is a little funny. I don't know, cameral probably has some Latin origins perhaps, or I don't really know. But the coronary is hooking up with a big vessel and a chamber that it shouldn't be. It's hooking up with the SVC in the right atrium. And because of that, your pressures are going to be very different, right? The flow is going to be very different. And that's what causes those coronaries to diffusely dilate like that. So when you see big coronaries, if they're sort of diffusely big, I worry, is there a fistula somewhere? What vessel or chamber is this thing hooking up with that it shouldn't be? And often it's very hard to visualize. You either have to scroll very slowly and sort of trace out the vessel, or you make these big maximal intensity projection images, which could be very helpful. And tricks to also look for too, notice, let me go back to, yeah, this one here. So on the right image, this is your right atrial appendage here. Notice that the contrast looks a little darker here, whereas it looks a lot brighter here. And this contrast looks very similar to the contrast within your coronary arteries. That is a little key and a little trick, right? If you notice contrast similar to your coronaries, that might be where it's dumping and where it shouldn't be. So your eye should be drawn there. All right, I've got one or two more cases, which should be perfect because we're sort of rounding out time here. This patient is presenting with worsening dyspnea, worsening orthopnea, doesn't really have any other leading history, no history of cancer, no recent infection, but his CT is quite impressive. So this is an axial CT, just a regular, I think, CTA chest. I really zoomed in on the heart just to show our findings well. And so let's remember where we're looking. So right atrium, right ventricle, left atrium, left ventricle. And it is a contrasted exam. I'll tell you that this right here is just contrast that's pooling. It's probably getting into the IVC. So what I noticed is what is all this stuff, right? This high density stuff that's around the heart. Now you don't have any vessels that normally course there, right? So although it looks similar to the contrast, this is a little bit different. And so the heart looks funny. Let's look at some of our cardiac planes. And here's an example of two cardiac planes that I made. If I can go forward, let's see. There we go. So here is a four chamber on the left, right atrium, right ventricle, left atrium, left ventricle. And this is a sword axis view. On the sword axis view, all you're doing is you're basically chopping down the donut, right? The donut is your left ventricle. If I make cuts in this orientation down the left ventricle, you get that good donut look. So notice that the left ventricle, the thick myocardium goes all the way around. But what is all this stuff around this? Anybody have an idea what that might be?
Calcification.
Yeah, calcification. And where? What structure is that calcifying?
Pericardium.
Yeah, pericardium, right? So by definition, when you see calcified pericardium, it is called constrictive pericarditis. right? And so there's a lot of different things that can cause that. You can get it from infections. You can get it in people who have certain infiltrative diseases. You can sometimes see it, but often it's idiopathic. So this person, they didn't really have any reason they could find. Maybe they had an infection in the past that nobody could figure out, but this person has pretty bad constricted pericarditis. And to go back, look at this person's right heart. It's very big, right? So when you get constricted pericarditis, your heart is just not able to pump the same way it can because it's not able to expand in the same way it normally does. That constrictive, that thick, fibrous, calcified pericardium is allowing your heart to not work properly. And so that's why the heart's abnormal. And so when you see this, it's automatic. It's constricted pericarditis. They can do different physical exams and echo findings and cardiac MRI findings to know if it's constricted physiology, but this is constricted pericarditis, period. Nice, great. Well, it's 10 o'clock now. I don't want to take up anybody else's time. Go to the end here. Thanks everybody, and I appreciate the participation as well. Thanks for bearing with me that the arrows weren't sure, or my mouse wasn't showing, but this was great. And I'm happy to